nothing but faith. There's things far too great that I want to accomplish. I'm hoping 25 hours a day, but something good works out, and I'm just like, dang. Think everything's gonna be okay. Yeah, I'm like, dang. Think you might just know the way. I'm like, dang.
Welcome to Dang.
Dang. I'm Todd Bridges.
And I'm Bettijo Bridges, and welcome to the 50th episode of Dang. Did you realize it's the 50th?
Wow, you mean I'm older than this show?
Yeah, well,
The
you are
episodes?
measured in years. The show is weekly.
Yeah,
so.
that's true. I'm measured in years,
But
unfortunately.
today we're joined by a couple of very special guests, Dr. Jared Dempsey and Kevin Jones of Trac9 Informatics. They're transforming addiction treatment with data using weekly assessments, predictive analysis, and analytics and evidence-backed measures to track clients' recovery, predict relapse risk, and help providers tailor better care with science. This is such an amazing topic, and we're diving into why they built Trac9 and how it's redefining what success means in recovery.
That's right.
Welcome, guys. Thanks for being here.
Thank you so much. Yeah.
So tell us a little bit about what Trac9 actually measures.
Well, I guess I can take that. So Trac9 is a standardized weekly battery that is basically taking a full psychological profile of a person's current mental functioning. So we look at things like depression, anxiety, stress, even down to things, all science-based, even down to things like spirituality. So how we determined what was in the battery was very simple. We just said, okay, our goal is to get them sober. What things best predict people staying sober? So that led us to the 9 variables.
Awesome.
Well, what
Okay.
made you guys decide to build this tool? I mean, what problem were you trying to fix?
Yeah, I think the problem we're trying to fix is that most treatment that happens, they don't measure progress that's happening. So oftentimes you don't know if patients, clients are getting better. So if you're going to make treatment better, you have to be able to measure it. You know, what gets measured gets
Yes.
done.
Yeah,
That's kind of
absolutely.
the basic idea behind it. And then the idea of applying the science-based measures of what really matters for recovery, for successful recovery. So selecting the measures was something that is important to get the right measures, and then how they get used in treatment. And we did it because we wanted to improve treatment and improve patients' lives and reduce relapses and reduce deaths that come from that.
Oh, yeah, I could have definitely contested that if I would have had a rehab that was designed for me to go to. I didn't find that until I was like on my 6th rehab. That, even though I didn't want to be there, I think that there's still ways that they can help you. Because even at the 6th one, I really didn't want to be there, but they knew how to fix me, how to get me better, to get me, be able to get on myself, and have a life in recovery, you know?
Dr. Dempsey, I've heard you speak in the past where you've talked about the addiction recovery space a little bit as like a Wild West. What was it like before Trac9 existed? Like, what kind of was the environment that made you say, we need to do this?
Well, it was the Wild Wild West. We're getting out of there, thank goodness. But essentially, so we had people who were not scientists, who were not even clinically trained, deciding what questions to ask the patients. So I would hear of marketing directors that were saying, creating questionnaires to determine how the patients are doing and how it's progressing over time, which is just absolutely ridiculous because the field of assessment is a scientific field called psychometrics.
What's the craziest question that you heard somebody ask? You don't have to tell us the place, but just tell us the questions you may remember, the craziest one.
Well, the craziest ones probably won't be as interesting to you guys, but there are big taboos in the field of psychometrics, like the concept of double-barreled questions. Like, do you like going to the movies and vanilla ice cream?
Oh, yeah, that's
And so then when they respond, it's like, well, which one are they talking about?
Yeah.
Right, yeah.
But what's more important that I think is helpful is the biggest problem was not only were they not using standardized science-based measures, but they weren't assessing the same thing for every patient. So this patient comes in, they seem kind of depressed. All right, let's track the depression. This one comes in, they're not that depressed. We don't need to track them. The problem with this is then you won't have the ability to determine each treatment center and have a national benchmark to say how are they doing on all these metrics. So for our customers, the treatment centers that use it, every patient gets every assessment over time. And that is going to allow you to truly see how the patient's doing.
Wow,
Yeah.
gotcha.
Well, and I imagine it would be really difficult too when comparing treatment centers also if you have no real evidence, no metrics to point to say one center is better than the other or anything like that.
Yeah, exactly. So if you're a patient trying to find a treatment center, how do you know which one's better? You know, one might say, you know, we do this treatment, but you don't know if that treatment works. But there's no measures of how successful they are at doing it. So it provides a way to compare, you know, outcomes at treatment facilities. And it provides a way when you drill down into it to know, like, if I have this certain condition, is there a treatment center that's better for me for the thing that I have, right? Which is kind of the next level of all this.
Yeah.
Yeah, and I found that it was like I went to this one treatment center. I won't mention any names, and they allowed me to go on the walk the first day. And that's like the dumbest move you can ever do for a person who's just coming into recovery. And they were walking, you know, like, hi-de-ho. They kept going that way, and they let me be in the back, too. So I'm like, hi-de, and I went that direction. Did not stop.
Well, what you're talking about is called AMA, leaving AMA against medical advice.
Oh, yeah, that I definitely did.
And it's a big problem. So when we look at federal estimates, that they estimate for residential treatment and addiction, about 30% of patients do what you did.
Wow.
They bolt right away.
Yeah.
But think about it, especially with the day and age of fentanyl, a percentage of those people will go and use, some of them overdose, so that AMA equals death.
Oh, yeah, it does.
Yeah.
So that's part of what we target. And Kevin might be able to speak to the differences between our customers, speak to it a little bit. But we actually target and project. We have a computer learning system that predicts patients like you during that one stay.
Oh, wow,
Where
okay.
when you come in, we assess the psychological profile. We've already identified the profile of a person who's going to go into residential treatment and then immediately run.
Oh, they would have got me then. See, that's why they should have put me in a lock facility for a few days.
I just love this idea that you're able to predict. What other things can you see with the data?
Oh my goodness, we've got a couple new features coming out, but there are a lot of things we can see. But the most important one is keeping them in treatment. So we use a predictive algorithm, and I will tell you that when we first started this, that I was a little bit myopic as a scientist in that I thought, oh, I'll just take all of our national data, I'll get one algorithm to rule them all, and I can predict all the patients and who's going to leave AMA. Where the secret sauce is understanding that, and you guys might be able to speak to this, that every treatment center is so incredibly different.
Yeah.
And different treatment centers have different things that predict whether a patient's going to run.
Yeah.
Some of them don't allow day one walks in the back, you know. And so what we had to do is use computer learning. We scan every individual facility's year-long worth of data, and then we build a custom algorithm for that one location that predicts who is going to leave from that location.
So when you had first come in, if you had used Trac9 at that place, they could say, Todd's a guy who's warning, you know, likely to leave. And they would come to you and say, Todd, we know you might be thinking of leaving. If you are thinking of leaving, they give you some special attention to know that
exactly.
that they're looking after you. And that would have kept you in treatment. Because if you're not, you know, obviously if you don't complete treatment, you're not going to get better.
Yeah,
right?
if they had putting me in the back alone by myself was not a smart move, you know what I mean, for the type of addict that I was at that time.
Right.
But what I think what makes it different from back then when I got sober, which is 32 years ago, and now is literally, I think it was life and death then, but now it's really life and death. This is no joke anymore. People are just, you know, not being able to come back. You know, that's because when I ran sober living houses, that's one of the things I used to tell people was like, if you go out, I said, there's no guarantee you're going to get back. And I go, you're going to either die or you're going to end in jail. And that's exactly what will happen. It's one or the other, you know. And I'm glad that you're making this so that people can figure out what's really going on and really help people. I think the more data and recovery you guys can get, the better it's going to be for people in the program.
Oh, absolutely. So we've got these new features that have just released. So we've got the world's largest repository. So we've got 7.5 million individual assessments on people going through recovery.
Okay.
Now, why is that important? Well, think about if you have a measure of depression. And then the scientists have given you a number saying above this level, someone very likely is struggling with depression. Well, if you gave that to every person going into residential treatment during week one, we'd be diagnosing every single person with major depressive disorder. So what you need to know is what is normal and expected for level of depression, anxiety, stress for someone who goes into residential during week one who successfully complete the program. So it's modeling that out. We've since refined that, and we now have the ability, because we do follow-ups after the patient leaves, we now have the ability to estimate the likelihood of relapse every single week for the entire year post-discharge. So on the patient's chart, when they first come in, and it's based on how they're doing, their current psychological status, and it's based on all the data we have, it'll say this patient has a 72% chance of relapsing within the first year if they leave right now. And then the next week, you'll see that coming down. But what was very important to us is we want to really promote science-based treatment. And so what we do is based on each individual's patient going through the system with this algorithm that predicts if they're going to relapse, we know what about that patient is increasing the risk they're going to relapse. So then it tells the therapist, hey, you really need to lower this depression. If you lower the depression to this level, their reduction is going to be at this level. So it's actually telling them how to do it and what to do.
So this is like an interface that people on the ground in the treatment centers have access to. So they're not just that you're measuring all this data, but that you actually give them kind of feedback that's usable.
Yeah, exactly. So the patient does the assessments, and then the therapist doesn't have to spend any time doing the assessment, but they can spend the first minute or two at the beginning of the therapy session and look at the results. We present all the results right there to the therapist with all these sorts of warnings. So, for example, if the Jared mentioned we track what's normal progress through treatment. So the flip side of that is we alert the therapist if the patient's not on track for successful treatment.
Wow, that's great.
And then we say, okay, you're not really tracking correctly to be having successful treatment outcomes, and this is what we should do with you, and getting the patient engaged with that. And then the other thing I wanted to add to, as they're looking through the relapse risk, say if your relapse risk is 72%, if you were to leave right now, what we're hearing from the therapist is that's incredibly motivating for the patients to say, I guess I do need to stay, right? And complete this treatment, because you do the math of 72%, and a third of those people might die from overdose, like we're talking about, and it kind of puts it right there in black and white. So we give that all to the therapist to have as part of the discussion in therapy.
I love this so much, because one of the things I think about addiction, just by its very nature, is that you have no control, right? That when there is an addict, they're acting on compulsions that they have no control over, that they are kind of almost in a way psychologically being forced into these things. And I love how the data is restoring that control, right? Like what's the quote that if something that's not measured is not controlled or managed or whatever. I think if it's not measured, it's not managed. But I love this idea of the data being kind of one of those first ground networks of giving people some power back over their addiction. Well, I think giving them a tool.
Yeah, I think it has a lot to do with the fact that it's it's like I have all the control right now, but if I use, that's when I lose all my control. And I think for a lot of people that I've learned is you see some of these people, and if they just would, my brain wasn't producing sulfuric acid at the time because all the drugs I did had destroyed it. So I was blessed enough to where I had psychiatrists who did an evaluation of me and figured it out. He goes, you need Depakote. You need to start taking this medication. He goes, it will help kick that back in. I started taking that. So then before I was relapsing this program, I would think about it and go, nah, I'm not doing that. I don't want to blow that. Blow what time that I had here. But it took a bunch of different people doing different things. So the psychiatrist assessment, my counselor's assessment, it was all the assessment that they did. And this was the first program that I had seen that did all these things. So I think with your data, that's going to be incredible, But with your data, what has surprised you about all the data you've gotten so far? What's the most thing that has surprised you about it?
The surprising thing for me is you have such a wide spectrum of different types of therapists that are treating these patients. You can go from a doctoral level, which is my field, clinical psychology, to a master's, to a submaster's. So there's a very wide spectrum. Now, unfortunately, Kevin and I, when we started this company, we thought, all right, we're going to get the data. We're going to give it to the therapist. They're going to know what to do. But kind of like how Todd said, well, thank God I met the psychiatrist that understood A plus B equals. So what we found is that the vast majority of therapists were never trained in how to utilize psychological data inside therapy.
Wow.
So we have to actually take that over when we do the training. And what the most surprising thing to me, it was more of a pleasant surprise, is being able to create algorithms that can assist the therapist of potential issues, not just disorders, but we have a new feature that's rolled out where it looks for certain movement patterns in the data, and then it's talking to the therapist. So it'll say things like, are you sure we don't need to screen for bipolar here? Because it's seeing the patterns move.
Gotcha.
Even as sophisticated as if it sees that spirituality increases and trauma increases, and then spirituality comes down and trauma goes down, then it tells the therapist, hey, there may be some spiritual trauma here. You might want to check in on it. Because we need more people who are identifying these causal factors of relapse and not let this person just go back on the street and have the same issues. Like Todd said, it's now life or death. I was talking to Dr. Andrew Hoon in Johns Hopkins, and he's saying they're putting fentanyl in weed now.
Yeah.
In weed.
Oh, really?
Yeah. So it truly is life or death.
Yeah, I realized how bad it was is when I watch some videos sometimes of people on the street in Phoenix that are on these things called blues, I guess. And they're not standing normal like normal people. You know what I mean? It's like they're on heroin. They're like leant over and they're just sitting there, or they're just sprawled out, and you're like, wow, this is something real serious that's kicking, our country. And to me, it's doing us in. And if we don't get a hold of this fast enough, we're going to lose a major part of our people in this country.
I think it was somewhere, actually, Dr. Dempsey, I think it might have even come from you, that something like a plane crash a day worth of people that are...
It's absolutely insane. So we've got more people, addiction's killing more people than all the car crashes each year. Addiction's killing more people than prostate cancer, breast cancer, thyroid cancer. And yet the resources we're putting into the treatment is incredibly low, which is just astonishing to me, because if we have a disease that's killing more people than several forms of cancer, why are we skimping on the treatment? So thank goodness we're getting better in this country about mental health parity, but the problem was pre-mental health parity. The resources were so slim, they had to find a way to provide some form of treatment. And so now we're finally catching up and advancing as a field.
And I mean, this is the world we live in right now, right? And so there's this wide variety of education level, skill level of therapists. One thing we realized that's what we have. So we wanted to make a tool, and we're calling it a therapeutic co-pilot. So this therapeutic co-pilot can tell the therapist, here's a number of things, alerts of things that could happen, like they might be at risk of leaving EMA, or here's some potential diagnoses you want to look into, potential issues you might want to check into. Here's some potential treatments you want to think about. Here's some treatment guides you can use to follow to do the treatments. So
now, is this a tool that would be available beyond just rehab, but also just for therapy in general, just like your typical mental health?
So we actually, the product is, the start of it was for substance use disorder treatment. We have branched into regular plain, mental health treatment as well. So it's used across the whole domain of mental health, behavioral health, and does all these things we're talking about there are some things that are specific to substance use disorder, but all the therapeutic co-pilot type of functionalities are for all the therapists.
I mean, from a scientific standpoint, it is a disease. It's a biological malfunction, right? But why do you think it is that it is looked at and treated so much differently than, say, something like breast cancer or something that is more, you know what I'm saying? Like, why is there that difference? What do you think?
Well, I could speculate, but a lot of it is societal stigma. We have to get past. I mean, there are a lot of other disorders that we don't realize that in the past we had different stigmas that, thank goodness, are no longer there. Early on, in the medical literature and what physicians would tell parents whose children were autistic, they said, well, this is because you didn't show them enough love.
Oh, wow.
And that was initially thought to be the origin. Well, some of the origins of addiction, which we still have the residual of now, is people think, oh, well, this is just their choice. Oh, they're just lazy.
Absolutely. I think you're right. We've made strides, but I still think it's absolutely present, right? Like as a parent, it would be a lot easier to be like, oh, my child has, leukemia, right? Or my child has substance use disorder. That's a totally different ballgame. So I think there is still that stigma. It's gotten better, but it still exists. Yeah.
Right.
Well, yeah, but the reason why I know that that's exactly true is because it's like, I would do drugs. I can't stop. I'm on a run until I'm dead. And then I'd be with somebody and they do a drug and they're like, oh, that's too strong. I can't do that.
Right.
And I'm like, why couldn't I say that? You know what I mean? Why didn't my brain say that? But it's because that shows you there's a difference between us two. The
Right.
addiction is I have the addiction quality inside of me for that. And it was interesting how people would go through that. But I think what scares me the most is I think when I first started in this program 32 years ago, it was frowned upon, and you were like the enemy. You were the worst person ever to go through that. And they thought it was, he made a bad choice. But you see today, a lot of people are applauded for going through treatment, but I still think it's not on a bigger scope yet that it should be.
Yeah.
It has to be really looked at as a real disease, and people need help. And I think that especially with what you're doing, it'll make a huge difference to people, if they can get the help they really need.
Well, I can't imagine. I know you guys are a business, and you go out to these other treatment centers that are businesses and try to get them to use the tool. But why ever would they not want to use it? Like I just, what is that? Is that
Yeah,
a
I mean,
fair question?
it's interesting, and it kind of goes back to some of the things Jared was saying earlier. Historically, mental health and behavioral health did not have parity in terms of reimbursement by insurance, by Medicare, Medicaid, and insurance. And because there wasn't reimbursement for it, there was very little money available. So we do demos every week to treatment facilities who are interested, and I'd say 99 times out of 100, like, this is so awesome, this is great. And then they try to think about how they're going to afford it in their budget.
Right.
Oh, yeah.
Right? They're kind of scraping by. And, if you look at the statistics, a lot of treatment centers are, not making it every year, right? So it's very, very hard with the reimbursement that exists right now. So, we recognize that that's just a reality that we have to deal with right now. So one of the missions that we're on is to convince the payers,
Oh, yeah.
right, that this is something that's good for everybody. It's obviously good for the patients.
Right.
It's good for the payers in terms of if people aren't relapsing and going back to the
That's
emergency
exactly right.
department.
And by payer, you mean like insurance
The insurance
companies?
payers, yep,
Yeah.
exactly, insurance companies. It's going to save them money if treatment is more effective.
Right.
yeah.
So
Yeah.
therefore, they should pay for this tool that's going to help them save money. And so we actually are in the midst of talking to a state Medicaid payer to do exactly that, where the state would sponsor or pay for the Trac9 as the benefit for all the treatment providers to use with the patients.
Oh yeah.
And so I think that's what we're trying to get to. We're the first one. We're I think on the cusp of doing that one, but I think that's the trend that we can get to, where we can get it really to be widespread and used by everybody, not have treatment centers say, oh, I don't know if we can afford this.
Yeah.
Yeah.
And I got to tell you too that some of the reasons, most of the time, the very good treatment centers will come to us and say, we want to do better by our clients. And then the treatment centers that are cutting corners, or they don't care. They want to check the box. They just want something to do the minimum and then keep going. It's another problem in our field. It's a small proportion, but there are a certain level of treatment centers where their motives are not in helping these people get better.
Yeah.
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 And that's unfortunate. But thank goodness, I love the work that Kevin has been doing with these state officials, but we're moving towards more of a, how do you say it, Kevin? The better you do with patients, the more you get paid.
Yeah,
The value-based care.
Right. So value-based care type of, which is become a common term right now. So this is a perfect candidate for a value-based care arrangement where, and this is what the state is looking at as well, is they'll pay for value. right? So they get better
Yeah.
outcomes, they'll pay the treatment centers more
That makes a
to,
lot of
to
sense.
do the things you have to do to get that.
Yeah.
So think about that. Instead of these treatment centers being incentivized with heads in the bed, they're incentivized now to keep you sober. So it's like the treatment center or the payers might say, hey, we're going to pay you $1,000 a day to keep Todd in treatment. But if he stays sober for a year, we'll pay you $1,500 a day.
Oh, yeah, that makes a lot of sense. That's even better.
Yeah.
But if he relapses and he goes back, we're only paying you $500 a day.
Oh, yeah.
So it's incentivizing
That would give them
the
more of
right
an
thing.
incentive
Right,
to do
motivating
better.
the right
Yeah.
things.
For the right outcomes.
Motivating based on the right outcomes. Yeah. If you imagine a future of addiction treatment, what do you see out there? Where are we going?
You know, I think we've got a lot of work to do. And I'm excited to be on the team and have the team that we have right now. Part of the problem, even in general mental health, like Kevin said, we've got two sides of the system where it's non-addiction and addiction, so general mental health. So we've been working with some large companies that are just outpatient individual therapy. Bettijo's depressed, so she goes to see a therapist. And they're telling us about 30% of the people never come back after one session.
Oh, wow.
So what Kevin and I just finished doing, and we've finally deployed, about 2 weeks ago. It's exciting to see it launch. The therapists at these locations take a personality assessment once a year, and then the patients coming in take a brief personality assessment, and then based on 20 years of scientific research, we match them together. So that vibe you get sometimes with your medical professionals, where you're like, this dude gets me. Like we're optimizing that, which is
love
going to keep people in therapy longer.
I mean, we have like match services for dating. Why not have match service for your therapist, right?
It's the same exact idea. It's the same exact idea. I don't know what science is behind the dating side of it, but this side of it is all science-based. What studies have shown, different personality factors work well together, and certain ones work in conflict, don't work well together, right? So we've kind of created a matching model that's using multiple factors, looking at that and getting the best score possible. And so to hopefully help people not have to feel like they got a therapist shop, right?
Yeah. I love that. What do you guys recommend for for families that are looking for treatment? What is the best first step?
I'll tell you that, some of the, from all spectrums of socioeconomic status, groups, unfortunately what a lot of people are doing is they are just Googling what's the best treatment. And then unfortunately, who you're going to see is whoever is paying the most money to these search engines. So they could be the worst location or the best. Part of what we do is allow these centers to actually see privately how they actually perform. But we need to go towards that type of metric where we have a more objective, taking the money out of it, having a service that can allow the general consumer to look past the amount of money they're spending on marketing and look into true results. Now, if I were to tell you a good way, accreditation is an important one. So you could look for CAR for Joint Commission, and they evaluate the programs on a regular basis. If you wanted to go one step further, every city in the world has AA groups. And if you tap into some of those groups or some of those people in recovery and you ask them, they're immediately going to know who are the places to stay away from, who to go.
Yeah, they will.
That's actually been one of the biggest recommendations that we get a lot is just to go looking for recommendations, like go through word of mouth, that's really the best way. Avoid Google, like you said. And that really is why actually Trac9 is our partner in My Best Rehab Foundation, which is Todd and I, our nonprofit that we've started, where we are aiming to be that best first step when you're looking for treatment in creating a tool that will help people find treatment based on their specific circumstances, and that all of the treatment centers recommended in there will have been vetted for their outcomes. So we really appreciate you guys partnering with us on that. I think there's no way we could create a tool like the one we want without the support from you guys.
Yeah, it's definitely great having an opportunity to be able to really find a place. Like they don't have to go through 6 of them before they find the one that actually is going to work for them.
Yeah, absolutely.
Yeah, and I think treatment centers that are interested in sharing what their outcomes are, their outcome metrics, take it seriously. They care about the outcomes, right? And as a patient, that's what you want. You want to get better, right? And the ones that are talking about, I don't know what, not, we'd say non-evidence-based treatments, that might look good because it's a bougie luxury kind of place. Not that those are bad, but if they're not talking about what they can help you in terms of your recovery and your treatment and the outcomes they can get, then it's to us not quite as good.
Yeah. Does Trac9 do like the treatment center? I'm just curious. Do they have like a Trac9 logo sometimes on their website where they'd be able to tell like, oh, this center uses Trac9?
Yeah, I mean, we have a metrics program, certified metrics program, where we will provide the metrics, so we guarantee the metrics are correct and accurate. It's not just some places will make up certain metrics, like they have a 99% success rate.
We had almost every treatment center, but when Trac9 first started, every treatment center was making the claim, we have a 99% success rate. And I'm like, well, where the hell is your Nobel Prize? You've cured addiction. So they were all just making these numbers up.
Of course.
Right, so we'll provide certified data about their outcomes.
So that they can use that in promoting their center.
Exactly.
So that's another thing, I guess, to look for if you're evaluating a center. Do they have something? You can even ask them, what do you use to measure the psychoanalytics so that we know that we're progressing? Like that's another thing to look for. Well, I love it.
Definitely. You can always tell though when a treatment center is good. Like the treatment center that I finally got sober in, it was like my insurance ran out and they still didn't let me go anywhere.
That's a good location.
They were like, you're staying. They're like, you need to stay a little longer. And then I was like, then you need to stay a couple more weeks. And then finally like, okay, you can go to it. And then they actually came to me and was like, you should go into sober living. That's the only way you're gonna make it. And I went into sober living, and then sober living had to kick me out because I didn't want to leave. I wasn't me. I was there like 17 months. I was like, this is the greatest place ever. And they were like, you gotta go. You're doing great. Get out.
Right.
You're ready.
I think we have a term for that in the recovery community. It's called pink clouding. You're just so in love with recovery.
No, it was like 17 months. I've been sober.
Oh, so you were just thrilled.
Yeah. They were just like, I just like because it felt so safe.
You didn't want to leave, so you started running it.
Well, no, I later on got my own place. It was so safe. It was safe. And it wasn't safe outside of that, I thought.
Yeah.
And that's when they're like, you got to go live your life, and and you need to start, and set my boundaries, and that's what I end up doing. So,
yeah,
and it worked.
Yeah.
Well, it's ToddFlix time. We actually have a segment on our show where we talk about the show that Todd and I are binging and loving lately. And this week,
but it's Resident Alien, but we haven't seen. I guess
we just found out prepping for this show that there's a fourth season that had.
But I heard why it got canceled. It's called Resident Alien. It got canceled because they didn't like the amount of money they were spending on it. But it's called Resident Alien. It's about this alien who comes down from outer space, and he comes down with intentions on destroying the world. And then he meets all these people, and then he starts, enjoying being there. And then he doesn't want nothing to happen to the Earth. And then he finds these other aliens who are there trying to destroy the world also. So now they're trying to solve them. So
the alien is played by Alan. Is it Tudyk? How do you say that?
I don't know. Where is it?
Right there. Is it? Alan?
Yeah. Alan Tudyk.
I don't know his.
Alan Tudyk.
Yeah, I've seen it written, but I've never heard it pronounced.
It has to be.
He's the guy from Firefly and
he's
Doom
hilarious.
Patrol.
This guy is hysterical. He plays this character so great.
And he's done a lot of Disney voices too, which he uses that in the show. Like he does like some voices.
Well, he also played the robot in the new Superman. Number 4.
Okay. And in the show, he looks like a doctor. He takes the body of this town doctor in this like rural Colorado town. And he, but occasionally you see his alien form.
Yeah. Well, no, only certain people can see his alien form.
Well, they show it to
kid.
Like there is a
kid who sees it right off. This kid looks and goes, and runs because he knows who he is, and then finally they become friends.
Yes.
And then but what makes it interesting is how he becomes a doctor and does so well in the show is that he's going to YouTube. He's like, they need a. And he talks and he says really dumb things, really stupid. His jokes are terrible. People are like, this guy is really. They think he's just really weird guy. They don't realize he's an alien. So
yeah, it's. I think it's funny to have like a humorous sci-fi comedy too. Like
it definitely is.
What was that one from the 80s? Like Alf. Was it Alf? Where it was the alien coming out? Anyway, this is way better.
But that was a puppet.
This is way better than.
Well, yeah, because this is AI or CGI. But they're also the lady from Lyndall Hamilton's in it. The lady from Terminator's in it.
Oh, you're right. She's the government.
Yes.
I also remember her from the really ancient Beauty and the Beast TV show.
Oh, really?
Do you remember
Yeah.
that?
Yes.
It was a great show. I remember watching that as a kid. So you can stream Resident Alien
Yep.
all 4 seasons on Peacock, and there's
Yep.
some seasons on Netflix too. That
Yeah.
might be why we've only seen
Yeah,
the,
'cause we watched
maybe
it
we
on
were all
Netflix.
watching on
You're
Netflix
probably
and we
right.
didn't have the last season
Yeah.
or something.
Yep.
But it's a funny
Definitely
show.
Yes, it is. So check it out. All right. Well, dang.
Dang. Do you guys
I'm
want to
Todd
say
Bridges.
dang?
This is Bettijo.
Dang.
Dang.
Please watch it, like, and subscribe, and we'll see
we'll
you next time on Dang. Bye-bye.
Bye.
Dang is produced by my wife, Betty Jo Bridges, in collaboration with Star Worldwide Network Studios, and edited by our daughter, Adelie Ann.
She's also the musician responsible for our theme music, so go check out Adelie Ann wherever you stream your music. Have a question or topic you want us to cover? Send us your suggestions at dangpodcast.com.
Do me a favor. Please subscribe and rate our podcast to make it easier for others to find. Have a great week.
Yeah, I'm like